Everyone. I'm Anastasia.
Hello, hello.
I am the current president of ICAN, and this is Jen Kimmel from VBAC Facts, and we are so excited that you are here. And we are going to get started in just a couple of seconds. And we took all the questions in from the forms, and I kind of put them in order to just sort of build through as we go. But I am going
Love
to let
it.
Jen introduce herself. I am so grateful that she is here and thankful that she's been connected and so supportive of ICANN for a lot of years.
Since the very beginning, since I had my C-section myself, I reached out to ICAN.
20
So, you
years.
know, 21 years ago, my sweet baby girl turned 21 yesterday. Can you even believe it? And I was sharing, while I see we've got some people who are loading in. While people load in, I'll just quickly share this story. So, my daughter was only 6 pounds, 13 ounces when she was born. And so she was a very small little baby. And I remember, I don't know if she was a month old, a couple months old, but I was walking around in Costco and I had her on one of those little front carriers. And this woman looked at me and she's like, "Oh, is that a doll?" And I was like, "No, no, it's not a doll." But then as I was sharing this story with Anastasia before we went live, she said, "Well, there are people who do that, who have these life." And I said, "I know, absolutely." And yet my sweet little baby was an actual baby. She was not a doll. And I was not walking around with Costco with a doll on my body. Has anyone else had this experience? Let me know in the chat. I'd love to know. Was your baby mistaken for a doll?
My baby was the same size as your baby and was not mistaken for a doll. Thankfully.
I know
Would be
they're
really
so
odd.
tiny. I
I
know it was a little odd. I was like, no, no, it's a real baby.
know.
So I am really excited. I love seeing some familiar names here. Barbara, glad you're here, Barbara. I'm going to be interviewing Barbara for the VBAC Facts podcast next month to talk about all of her experience in fighting VBAC bans. And she is a tremendous resource. And so I'm so excited. Hey, Barbara, I'm so excited to interview her and get to know the rest of you as much as we can during this next hour. We have so many excellent, excellent questions. And in fact, one question that Anastasia sent me today, I had an idea of what I thought the answer was, but I didn't know for sure. And so I actually did a little bit of research and preparation for today, and I can't wait to share with you what I found. And if it's your question, you'll have to let me know in the chat when your question is asked, and I'll be like, this is the question that I had to look up. If you're here, I'd love to know because it was a great question. And so,
Yay.
Anastasia, when you're ready,
Yeah,
take it
let's
away.
go. All right.
Let's go.
And just I'm gonna put a plug in for Jen. She just started a podcast, so if you want to go listen to it, go find it. It's Feedback Facts on Apple Play, on
It's
Apple Podcasts,
everywhere.
everything,
Yeah,
all the
everywhere you
things.
would get podcasts, including YouTube's. And also you can just go to the website. So I'm slowly moving the episodes onto the website. So if you go to episodes 1, 2, and the latest one, 13, are up on the site. So if you go to vbacfacts.com/E1, that'll take you to episode 1. E13 will take you to episode 13. Thank you, vbacfacts.com/podcast. So yeah, so you can get it anywhere. You can also read the transcript, watch the video, listen to the podcast up on the website. So, and Anastasia was episode, what was it, 12, 11? I can't remember.
Hang on.
But about Anastasia's community's fight in Santa Barbara, California against a VBAC ban. So, the whole mission of the podcast, which is really a tangential mission to the larger mission of VBAC Facts, is to show people what is possible relative to VBAC, whether that's having a VBAC, different attendance, different number of prior cesareans, as well as fighting VBAC bans and showing all the different configurations of hospitals that safely attend VBAC. So that way we can see this isn't just a one size fits all situation. When people talk about who's a candidate for VBAC or where a VBAC's safe, often people really want to give this very black or white, cut and dry explanation. And the reality is, as those of us who have been on this planet, life is a little bit more complicated than that and nuanced than that. And thankfully so, because then that means we aren't pigeonholed into these very strict criteria of what does a VBAC candidate mean or where is it safe to have a VBAC. It's all about risks and benefits and understanding how we can make VBAC as safe as possible in all settings. So I can already feel myself going off. And this is about the questions that we have prepared today.
Which we're
So,
totally going to come back to that. So we'll start.
yes.
So we're going to start with, does having a single closure from my cesarean impact my chances for a VBAC?
You know, I have a single layer suture on my C-section. And I remember between my C-section and my VBAC, Ina May wrote an article, I think it was in mothering.com, about, or Mothering Magazine at the time. I don't even know if they published that magazine anymore. And it talked about the dangers of single layer suture. And my mind was just like, oh no, that's what I have. That's what I have. So this was before VBAC Facts was even launched. I believe that's when that article came out, because, or it might have even been afterwards, either which way. I started looking into the studies that she cited. And in fact, now within professional membership, within VBAC Facts professional membership, we have a whole training going through all of the research on single versus dual layer suturing and looking at what does the available evidence say? What are the pros and cons of each? And how it all boils down to is that there is not strong evidence that indicates that one method of suture style is superior to another. So what does this mean for you? Should you ask for a certain type of closure? That is up to you on what you want to do. I personally would rather have the closure style that my physician has used 1,000 times before, rather than being the very first person or maybe the second person that they've tried a different closure style to what they're familiar with. And since we don't have compelling evidence either way, it really is something that should not provide you any benefit, and it shouldn't also provide you with any additional risk. And also, because we don't have strong evidence, no one should be risked out of a planned VBAC because of the suture style that they have. And also, I want to share that if anyone has any follow-up questions, put them in the chat because we will be pulling those in and those will go at the end of the list of the existing questions that we have. So that way we can try to we're just going to get through as many questions as we can today.
All right, awesome. Thanks. Okay, so the next question I got that we have on the list is the most common reason for a failed VBAC, which I don't always love that language. So a VBAC that turns into a repeat C-section would be.
Yes. And this was actually the question that prompted me to go do, I spent like 30 minutes reading today because I had my own ideas of what I thought it would be. Because when we think about a vaginal birth without a prior cesarean versus a planned VBAC, the mechanisms of childbirth are exactly the same. The only difference would be is if there was some level of bias or how planned VBACs are treated differently than a non-VBAC labor. So when we just look at primary C-sections, and I'm going to pull up my notes here. Okay, so when we just look at primary C-sections, one of the things that I love to share is that 74% of primary C-sections, and that's a C-section that happens for the first time on someone. So like their first C-section. So we're talking about first-time C-sections. 74% of first-time C-sections occur for three primary reasons. One is labor arrest. So that's what we would call failure to progress. Malpresentation, so the baby is in whether it is a breech presentation and the provider isn't trained in vaginal breech birth, or maybe we have a face presentation or a hand presentation, some sort of presentation that expresses a greater level of risk, which would indicate a planned cesarean. And then the third reason is non-reassuring fetal tracings. So when I saw this question, I thought, I'm sure it's similar, or if not very much the same reasons for a primary C-section as a repeat C-section. But you know me, who knows me? Raise your hand in the chat. I wanted to actually see, was there research out there? Because typically when I read research on VBACs, they talk about, maybe someone has preeclampsia but the whole concept of failure to progress, Why people have repeat C-sections, that's not always broken out in the research. It's just did they or didn't they? So I wanted to see what I could find. So I found a small study from 2006 that looked at 138 people who had a repeat cesarean delivery with labor. 60%, it was for failure to progress. So for first-time C-sections, that's about 34%. So is there a difference? And also 134 women, that's a small sample size, but still, for the sake of this conversation, then I would say, okay, are these planned VBAC labors viewed differently than first-time labors? Since we have 60% of those repeat C-sections were for failure to progress, as opposed to only 34% in first-time C-sections. The other factor was 25% were for non-reassuring fetal heart rate. That's pretty consistent with that 23% among first-time C-sections. 8% were for CPD, so that's when they say the baby's head cannot fit through the pelvis. And another 7% were due to maternal requests during labor. And what was very interesting is that fetal indications were less common. That was only 6% of those repeat C-sections. So that included things like breech, failed vacuum, placental abruption, other maternal complications. Oh, I'm sorry. So fetal indications were less common. That was 6%. So then they list out a whole bunch of outcomes, of which 5% accounted for 5% of those repeat C-sections. So breech, failed vacuum, placental abruption, maternal complications, and failed forceps. So interesting. So the three major reasons, or the two major reasons, were similar to primary C-sections. That's failure to progress and non-reassuring fetal heart rate. Is anyone interested in that level of detail? Or are you just like, give me the bullet points, Jen? Let me know in the chat, because you know me, I like the detail. But, I'm curious to hear what other people like. Okay, next question.
Okay. I would like to know how uterine extension, specifically going horizontal or towards the cervix, how it impacts VBAC. And I don't know, maybe we can, let me explain that a little bit more in case someone doesn't know what it is. So,
Yeah.
a low transverse C-section would just be, it's like a smiley face, like across the bottom of your uterus. So an extension would be they get in there and they're struggling to maybe get the baby out, in the small incision that they've made. So they either go wider or sometimes even go a little bit vertical, or you can have, there's actually a lot of different ways that it can go. You can have like a J and different things like that. So that's my explanation as to what she's talking about there with a C-section or an extension. So go for it.
When I have looked into research on scar extensions, I have not found any sort of strong evidence on this topic. And I think one of the reasons could be is, like you said, the extensions all differ. Is the extension horizontal? Is the extension vertical? How long is the extension? So all of these things would be things that would need to be controlled when we're looking at research. So if we wanted to look at, say, a horizontal extension, then they would want to sit there and measure, okay, so a horizontal extension, that's only maybe 3 centimeters, then maybe 6 centimeters, looking at the different lengths and then measuring the outcomes, and then finding enough people in that study in order to make their conclusions meaningful. Because if we only have, say, 5 people, that's not going to be a compelling study. If we only have 100 people, that's not a compelling study. So I think one of the reasons why there are some areas that we don't have good research, like in the example of extensions, is because trying to find enough people who qualify for that research in order to make that study strong, that for whatever reason is not a topic that researchers have focused on or prioritized. So the short answer is we do not have good data on that question. And so this is an area of unknown risk. So in any situation, when we're looking at times of unknown risk, there are specific questions you can ask yourself. Things like, how do I feel about the unknown risk of a planned VBAC versus the known risk and complications that come with repeat C-sections? Another question to ask yourself is, how many more children do I intend to have? If you want to have several more children, then that might be a different conversation, because if you want to have several more VBACs or several more C-sections. So looking at the long-term implications of your current decisions. And then the third question would be, how important is it to you to avoid surgery? And I'm also curious to hear from other people, or even other people who are here on the Zoom call with me and attendees. What other questions do you think would be relevant? When you think of yourself in this situation, what are questions that you would ask of yourself? So let us know in the chat, because I think that's an important consideration, is that, I can give my perspective and my experience, but it's always so interesting when I ask other people, well, what would you do? What were the questions you would think of? And I like having that well-rounded other people's perspectives in addition to my own approach.
Thanks,
So
Jen.
Anastasia, I
Yes.
mean, put you on the spot. What do you
Okay.
think about extensions?
Um, well, it was funny. I love the way that you asked like the questions you asked about it to like help you reflect on it. Um, and I think that, it- I in my head know who my care provider would be if I was attempting a VBAC. And so thinking of that person taking care of me, my answer would be that I would go with the unknown risk, because I trust that care provider so much to watch for signs that things aren't going well.
Yeah.
And my answer might change how it, depending on who was taking care of me. But knowing that, I think that I would choose the unknown risk over the known risk. Um, yeah, of another C-section. But
Well, and that makes me think of something else. I mean, whether we're talking about the risk of uterine rupture after one C-sections, with extensions after two C-sections, after an atypical scar type, at the end of the day, it's all about rapid and accurate diagnosis and response. And so if you are in a facility that attends labor and delivery, they have protocols in place to ensure rapid, or to maximize the odds of rapid diagnosis and response. So that's another factor. It's like, if you are in the hospital, that's one conversation. If you're out in the community, that's another conversation. And there are pros and cons to each location.
yep.
So, and at the end of the day, it's all about response.
Yeah, totally. All right. Next question. Little more specific on this one. So
Okay.
I had an emergency C-section in July of 2021 at 9 centimeters due to fetal distress, and a planned C-section in July of 2022. I am pregnant and due in October of 2025 this year. What are the possibilities for a successful VBAC? I will be 35 by the time the baby comes. What are my chances?
This is a great question, because there are so many factors that play into whether you have a VBAC or not. It's almost like, on your wedding day, for you to turn to someone else and say, okay, so here are some things about my partner and I. What are the odds that we'll get a divorce? There's a lot of stuff that could happen. There's infinite numbers of things. So when we think about labor, I mean, I think about the 5 Ps of labor, the power. So we got the contractions, we have the psyche, we've got the soft tissues, we've got, help me out, what are the rest of them?
Power,
Movement. Yeah,
power, yeah. Oh my gosh. Power position.
there we go.
Oh, why? I know these.
Power position. I know, seriously, power position, psyche.
I think that's it. It's the 3 Ps.
I have 5 Ps in my presentation, and I can't remember what those other 2 Ps are. But
Those
I
are
mean,
very
so
important ones.
exactly.
Yes.
So, for example, someone might have their first C-section. So you had your C-section, your first one, at 9 centimeters for fetal distress. There are so many factors that could have played out that resulted in that C-section. Maybe there was induction at play. Maybe there was an epidural at play. Maybe there wasn't freedom of movement. Maybe there was some emotional stuff going on. I mean, there are so many things that go into how a labor plays out. And so you could change up one of those things and have an entirely different outcome. So, we can plug numbers into VBAC calculators and people can give you odds. The VBAC calculators chronically underpredict. You can go to episode 6 of the VBAC Facts podcast or go to vbacfacts.com/calculator. If you asked 5 different OBs this question, they would probably give you 5 different answers, relying on putting more emphasis on specific factors. And the reality is, no one knows how your labor is going to play out until you're in the moment. So, things that I would do to maximize your odds: labor spontaneously. If it's possible to avoid induction, avoid induction. We know from the research that people who are admitted to the hospital and are at least 4 centimeters have higher VBAC odds than people who are less than 4 centimeters. Um, One of the things, I had just interviewed Dr. Chris Stroud for the VBAC Facts podcast, and he talks about his 4 pillars of VBAC success. The first one was aggressive education. And so he talked about learning the facts and, you know, he loves VBAC facts. So he recommended The Truth About VBAC for Families, which of course I do too, if you go to vbacfacts.com. And he also talked about, well, you'll have to listen to the rest of the podcast for all of those 4 Ps, because honestly, I can't remember them all right now. Aggressive education. Oh, picking your provider carefully. That was a huge thing that he talked about, because you might really like your provider, but if they're in a larger group and not everyone in that group practices the same, that could drastically impact your VBAC odds. If you have the one person in that group who doesn't support VBAC, who's called in for your labor, that can have a massive impact on whether you have a VBAC or not. So that would be one thing, is qualifying all of your providers in that group are supportive of VBAC. And another P he had, or another factor of pillar of VBAC success, as he said, is aggressive, what did he say? Nutrition, fitness, just trying to take care of yourself as much as possible. Eat good food, move your body, seek chiropractic care. And for the 4th pillar, you're going to have to listen to the podcast. So you can go to vbacfacts.com/E13 to listen to that podcast. It was great. And if you don't want to listen to the whole thing, you can scroll down and click on the markers and just go straight to the 4 pillars of VBAC success. But I have a feeling you're going to want to listen to the whole thing because it was really good.
Awesome. I'm going to add in doulas, increase odds.
Yes. Yeah. And
Any
what other
birth.
things would you add in? What other things would you add?
Actually, I mean, so far, like the one, taking care of yourself. So like what I work with a lot of people on is optimal, or talk to people about a lot of times, is optimal fetal positioning. So, right, nothing's a guarantee,
Yes.
but we live in a culture
Yes.
that actually encourages malpositioned babies, just the way that we live life. And so really being cognizant of how you're sitting and how you're standing and how you're moving your body, makes a world of difference, but also the physical and the psychological are on the same level in my.
Yes.
So you can't do one without you have to be in both spots.
Well, and that brings up a great point, is if your baby was, say, posterior the first time, and maybe that is what led to that C-section at 9 centimeters or contributed to, and the next time your baby isn't posterior, that one thing could make all the difference.
Yeah.
So again, there are so many factors in pregnancy and in labor that can really drive you towards a VBAC or drive you towards a C-section. And it's just kind of like the layers and like a 5-layer guacamole dip, right? You've got each layer, and it can either start driving you in one direction or driving you into another. And so when I think of things like a posterior baby, limited movement, you don't have the support of a doula, maybe you have an epidural, maybe you're exhausted, maybe you've been laboring for 24 hours and you're exhausted. So you have all of these layers that come together that take you down this path. And so the more layers that you can put together in order to put you down the path to a vaginal birth, and freedom of movement is so important. And so I think that's a really important question to ask your provider prenatally, is how do they feel about freedom of movement? And because if that's something you want to do, say, this is something I want to do. So how can we make that happen?
Yep. Huge. Okay, next question, so we can try to get through some more. Recommendations for women who have never labored during their first pregnancy and had to deliver prematurely due to a contingent condition like
Mm,
preeclampsia or HELP,
yeah.
who want to go for Tolac for pregnancy number two. This is like the personal side of it. I think there's like, right, the big broad, there's lots of people who had their C-sections without laboring, so that will cover a big piece. But then also this preeclampsia piece. And then some providers do not want women who had, this one I've never heard before, who've had
Yeah.
preeclampsia before once to go past 37 weeks, even if they are preeclampsia free, which is
Yeah.
very interesting to me. And an early induction will likely result in a C-section.
Yeah, when I read that question, I was kind of like, huh, because I too had never heard of that. Because here's the thing, spontaneous labor is the safest choice. In the absence of some medical indication, and preeclampsia would be that medical indication, right? And at that point, a discussion could be had. Do we want to do an induction? Do we want to go straight to C-section? There's a lot of factors that indicate whether you go down one road or another. Namely, one of those factors, the main factor, I think, is the severity of the preeclampsia at the time. So I mean, if this was me, I would be getting second opinions. Because the question is, what do you want, reader? If you're comfortable with another C-section, then this sounds like this might be a good plan. But it sounds like you would like to avoid that if possible. And it sounds like you and your provider may not be on the same page. So this is a time to have a conversation with your provider and say, hey, unless I have signs or symptoms that I'm becoming preeclamptic, I would like to avoid surgery. How can we make that happen? What do we need to do? What type of testing would you like to do? And then make a plan. And not tangentially, but at the same time, you can also look into your community for other options if you'd like. You can get, I know Dr. Chris Stroud, who I interviewed last week, he offers VBAC telemedicine consults. So you could schedule an appointment with him, get his opinion, and then use that. And when you go back and talk to your doctor and just say, well, I had another consultation. This is what they said. This is what I really want. And so again, I mean, it's always up to you. Even though providers' preferences or hospital policy might make you feel like you don't really have options. And in fact, someone just commented this on the VBAC on our Facebook account today. They said, when there's a medical indication, often consent is not received. It is not given because they just say, this is what you need to do. And I think it's really important for people to understand that you always have a choice and you always have the choice to say, wait, stop. I would like to talk about this. And in this situation, it's not an emergency, right? So you're talking about if you get preeclampsia, of course, we can talk about options then. And a question to ask them would be, if I develop preeclampsia, is induction on the table? Because some providers don't induce those with a prior cesarean at all. So to say, is induction on the table, or is that a time where you just recommend going straight to straight to repeat C-section? So this is a great opportunity to think about what you want, and then go talk with your provider and say, how can we make this happen? This is what I want to do. And wanting to avoid surgery is absolutely reasonable. And especially if you want more children, that is something to bring up. And to say to your provider, hey, I might want 1, 2, 3 more kids. I know if I have this second C-section, my odds of ever having a VBAC dramatically decline. And I will be likely locking myself into repeat C-sections for the remainder of my pregnancy. And dear readers, just aside, that's not because your body's not capable or the risks are astronomical. It's just because it becomes even more difficult to find a provider willing to attend that labor after 2 C-sections. So when you have 1 C-section, this is when your risks are the lowest. This is when your odds are the highest. And this is when you really get to advocate for yourself for what you want.
Yeah. I've never heard you've had preeclampsia before, so you have to have a baby at 37 weeks, even if you don't have preeclampsia again. So I'm just going to say,
Yeah.
I haven't heard that, so that would be something to question. Um,
Yeah, absolutely.
for a mom considering a VBAC after 3 C-sections, since we just said it's harder after 2, what would be her risks of poor outcomes such as uterine rupture?
This is such a great question. When you look online and when you look in message groups, you're going to see people cite all different types of numbers. And so a few years ago, when I decided to develop a training on this topic and I started diving into the research, I was really shocked with how little research exists on vaginal birth after 3 or more C-sections. And people will say, oh, well, there's this study here and there's that study there. Okay, that's true. Look at the sample sizes of those studies. One study and specifically I'm thinking about, it was a study that concluded, I can't even remember what the conclusion was. The conclusion was something like, it's reasonable to consider or something like that. They had 89 people in that study and they had no uterine ruptures. Well, one of the things when we look at studies and we look at uterine rupture is we always have to consider that important factor, the sample size. The smaller the sample size, the larger the likelihood that we have luck coming into play. And we're not actually measuring the real rate of uterine rupture. We're just measuring the randomness of uterine rupture. So if we only have 10 people in a study and 2 people have a uterine rupture, we can't say the rate of uterine rupture is 20%. Same if we had that same 10 people and we had no uterine ruptures. So when we look at the data on vaginal birth after 3 or more C-sections, we can't really say what the risk of uterine rupture is. It is another situation where we have levels of unknown risk. So we go back to those same questions. Okay, how do I feel about this unknown risk? Am I willing to take responsibility for the outcomes of this labor? That was something I didn't add the last time, but I think it's so important to bring that in. Because when we look at why providers don't attend VBAC, it's because they're worried about litigation. They're worried about there being a bad outcome and they will be held, quote, responsible and they will be sued. So when we are able to move the locus of responsibility and power from the provider to the patient, to you, then we're able to have a different conversation. So when you talk about levels of unknown risk and you're able to say, okay, we don't know what we don't have solid data on this factor. So how do I feel about that? Am I willing to take responsibility for the outcome? And what that means is that your provider will do what they can to generate the best outcome for you. But when we're talking about areas of potentially elevated and unknown risk, you really need to feel comfortable accepting the outcome, whatever that looks like. Another question to ask is, again, how important is it to you to have a vaginal birth? And also, how many more children do you want to have? So this is an area of unknown risk. And again, I think every single hospital across the country should attend higher order VBACs. Why? Because first of all, that's what ACOG says. ACOG says every hospital, every level 1 hospital throughout the country that has a labor and delivery unit should be offering VBAC. And the response for a uterine rupture after 3 C-sections is the same as the response for a uterine rupture after 1. You're either prepared to respond or you're not. So that onus is on the hospitals is to get their protocols together so they can respond quickly. But if they're attending labors, they should have that. So, and the other thing is that we want to make sure when people are choosing hospital birth versus home versus birth center birth, that they are able to freely choose from all of these options, as opposed to feeling like, oh, my only option is to have an unassisted birth. That's not ideal. If people want to plan an unassisted birth and they have all of their options in front of them, I mean, ultimately that is their choice. But when people are choosing things like unassisted birth because it is the only option available to them, that's a problem. And this is really a message to hospital administrators who threaten providers and say, hey, if you continue attending these VBACs, you lose hospital privileges. So sometimes providers who attend VBAC are in these sticky situations where they want to attend your VBAC, but at the same time, if there's a bad outcome and they are held, quote, responsible, they may lose their ability to attend VBACs in that community, period. So there is this push and pull. This push and pull of your right to make your informed decisions, your right to decline surgery, and also community access to VBAC and hospital administrators ultimately being able to pull that. So this is an example. I think we were talking beforehand about how people want black and white, they want up and down, they want right and wrong. These are complex topics, and there's a lot of moving parts.
Yep. So much. Lots of gray.
Yeah.
Yeah. Uterine windows or dehiscence
Mm.
after 2 prior cesareans. What do we know about VBAC or shifting when a planned cesarean can occur? I've hit roadblock after roadblock with all providers telling me I'll have to schedule at 36 to 37 weeks. How do I advocate? This is interesting. Just after 2 C-sections, how do I advocate for a scheduled C-section at 39 weeks or a VBAC?
So I saw this question and I had questions. So when I read this question, I thought, so she has a prior uterine window and a prior pregnancy, and because of that, they're telling her, or a current uterine window. How did you read that question, Anastasia?
You know what? Let me look and make sure I didn't cut anything off of it because I am seeing what you're talking about here. No, it doesn't
Well,
say. I actually wrote that one
yeah.
exactly the way that it was. So I'm not sure. I mean, maybe why don't we kind of address it like a couple of ways? So let's start with one. Can you diagnose a uterine window or a dehiscence in pregnancy?
So the only way it would be diagnosed during pregnancy would be via an ultrasound or an MRI. So,
And is that
or I mean,
accurate?
because is that accurate? That's a good question. I don't know how accurate those ultrasounds are in diagnosing uterine thickness, in determining uterine thickness.
Yeah.
Because when I think about dehiscences, there's a lot of things that come to mind. One, when are they noticed? So prenatally, they're noticed via an ultrasound or an MRI. The other time that they're noticed is when someone has a C-section and they open them up and they see it. Other than that, I think about how many uterine dehiscences that very certainly occur that are not noted because there is no ultrasound, there is no MRI, they're not measuring that, and there's no C-section. So how many people are delivering vaginally and there are uterine dehiscences and it's never noted and they go on and have subsequent children and it's not a big deal?
Yeah.
The other thing is that if you were to ask 5 different OBs what their thoughts were on the clinical implications of a uterine dehiscence, either in a prior pregnancy or in the current pregnancy, you would likely get 5 different answers. But I've never heard of anyone they recommended the C-section by 37 weeks. Is that what you said?
Yeah, which is odd.
That's
The only,
very early. That's
yeah, that
very early.
doesn't follow the 39 and fine rule.
Well, yeah, and even if someone has a complete uterine rupture, so that's a uterine, so both layers of the uterus are opening, that recommendation is 36 weeks at the minimum. So they're saying 37 weeks because you either had a prior window or a current window. Okay. That's actually one of the things Dr. Chris Stroud and I talked about on the latest podcast is he talked about uterine windows and how there is no clinical significance that we're aware of. So, do they increase the risk of uterine rupture? We don't have evidence for that. Do they increase the risk of any other complications? We don't have evidence for that. So, in the absence of strong evidence indicating that this would cause an issue in your pregnancy, to me, it seems severe to say you have to have a C-section at 37 weeks for this thing that we don't have strong evidence will even be an issue. So, how do you advocate for yourself? Doctor, I don't want a C-section. I want to wait for spontaneous labor. How can we make that happen?
And I would say
Decline surgery. Yeah,
sometimes
please go ahead.
asking them for the evidence, like you're sitting here saying, like, there's not really any,
Yes.
so flipping it back onto the provider who's kind of feeding you the sign, and this would probably go back to the other one about the preeclampsia too, is can you show me
Yes.
the evidence for that? And
Yes.
I've seen people that I've given that advice to come back to me and say, they looked at me and said, I don't have any. And then they had to backtrack. So it is a very powerful question to ask. Like, okay, you're making this recommendation. Can I see the evidence?
Yeah.
Put it back on
Yeah,
them.
because
Yeah.
yeah, because they won't be able to pull anything up. They might be able to pull up someone else's opinion
Hmm.
that has been written up, but in terms of research, and again, I go back to that idea that there are certainly many, many, many people who deliver vaginally with uterine windows or dehiscences, which are two words that are used interchangeably, that are never noticed. So again, this is something that is absolutely under the purview of provider preference.
Yeah. And you and I have both been on panels and heard OBGYNs talk about the uterine window and saying exactly what you've said, which is honestly,
Yeah.
they're probably happening all the time and we have no idea.
Yeah, exactly.
So
Exactly.
playing that in. Um, I'm gonna skip down a little just because I want to make sure this question gets answered because I think it's really important since this is going out to, anyone anywhere all over the world. And we know that we talked about finding supportive providers. So tips on how to navigate hospital birth when I haven't found a supportive provider there yet. And we know that sometimes people live in a place or a space where supportive providers actually aren't there and they aren't accessible. So
Yeah.
what do you do when that provider choice basically doesn't exist?
Yeah. Yeah. So number one is to understand what the evidence is, because it is very easy for someone to sit there and say, just like the situations we've discussed here, the preeclampsia question, the uterine window question, it's very easy for providers who aren't really supportive of VBAC and or carry a lot of fear for them to come up with reasons that might sound sort of sciency, but don't really have any evidence to back them up. So this is why it's so important for you to understand, what does the evidence say? So you are able to hear what they're saying and know what questions to ask. And to be able, in some cases, to be able to say, actually, the evidence doesn't say that. So that is the strongest weapon that you have in your arsenal. And come to vbacfacts.com, sign up for our email list. We have courses. You can sign up with a consultation call with me if you have a list of questions. So this is what we do, is provide people with objective and accurate information on vaginal birth after cesarean and repeat cesarean. The other component is to understand your rights. And we talk about that in the Truth About VBAC for Families. But to understand your rights and understand that you always have the option to say no. Now, our rights are clouded by biases that we have in our country. So if English isn't your first language, if you have a black or brown body, if you are of a lower socioeconomic status, if you are perceived this way or that way, it's going to be harder for you to exercise those rights. But those rights still exist. So that's an area of a little bit more finesse is required. The other thing is to understand that while having a provider who is super gung-ho and supportive and excited about VBACs, like, that is the ideal scenario. Unfortunately, providers like that are not available in many communities throughout the US and the world. So if you can't have a provider like that, what is the next best option? The next best option is a provider who respects your right to decline a C-section. These OBs, they know how to perform a C-section. This is not an unusual skill set. So you're just asking them, hold off on utilizing that. I don't want a C-section. What I want is an evidence-based option. These are the reasons why I want a vaginal birth. However, I also feel like we don't need to over explain ourselves, because anyone who is in healthcare should have the fundamental understanding that VBAC is an evidence-based choice to which the American College of OBGYNs and many other obstetrical guidelines in other countries all recommend access to. Why? Because it's an evidence-based choice. So you just want access to this evidence-based choice and to avoid surgery. And how can you work with me to make that happen? So that's the other thing. We don't need enthusiastic support, even though that would be incredible. You need someone who fundamentally sees you and honors your right to decline a C-section in the absence of a medical indication.
And the other thing I would
And also,
yeah,
I would also say hire a doula, because a doula knows the providers in the area. The doula is going to be able to help you navigate your options in a more effective way.
yep. And if you can't
Was there
hire
anything
a
else you were going
doula,
to say?
well, I was
Yeah.
gonna riff off that and then say one other thing, but if you can't hire a doula, you can also, like, if there's an ICAN chapter, like look up an ICAN chapter.
Yes.
Especially if you can find a local ICAN chapter, even if you can just email them, they oftentimes know the reputations of the different practices and what happens and the different personalities of people and things. And then the other thing I would
Yes.
say was write down your questions, write down
Yes.
the evidence that you have, because it is nerve-wracking to be in that situation. But if you have, even me, I'm like, Jen and I are friends, like we're very comfortable. But if I didn't have my list of questions, I'd get myself lost and forget where we were going. So you want to have that,
Yeah.
you don't get lost. There's a lawyer in town here who has been super supportive of ICANN, and she was cute. She was like, I had a notebook and I, wrote in the notebook, it was just for my pregnancy, it was just for my appointments. And I wrote the questions I had, and then I wrote the answers that I got in it. So having that, don't be embarrassed or nervous or afraid. Like, it is such a helpful tool to just have that.
And you saying that reminds me of a resource that I offer within the Truth About VBAC for Families. Is I actually formatted a document that has all of the questions, the evidence right next to the questions, and then space for you to write the replies of 3 different providers. So that way you have it right in front of you. So you ask the question and you have the cliff notes of what ACOG says right there. And so you can compare, what does the provider say as opposed to ACOG? And then you can write down their response as well as 2 other providers that you're interviewing. So that way you can easily compare what were their answers. So excellent, excellent resource. So you can go to vbacfacts.com/TAV for the truth about VBAC to learn more.
Perfect. See, don't even have to do, someone did it for you. I love that stuff. That makes me happy all the time. Okay. I'm just looking at our time and then picking.
I know we had so
Okay.
many good questions.
I know. I'm gonna go with this one because I'm curious about it. Why
Okay.
are rupture estimates coming from the UK and
Oh,
EU so much lower than in the US? A recent Royal College of Obstetrics and Gynecology material, so I'm guessing article, estimated it at 1 in 500. Just curious if you have a sense of this.
I'm so glad you asked this question. This was another question that prompted me to go, I have not seen this. Let me go look this up. And in fact, I did go look it up. And the most recent RCOG VBAC guidelines are from, was it 2015, 2016? And I actually looked it up. And in there they say 1 in 200. So I'm not sure where this number came from. If that person who asked this question is here, please supply it in the chat. I would love to see what you're talking about. And if anyone else knows, supply in the chat. You can even email me afterwards. You can go to vbacfacts.com/contact and email me the link to the study. I would love to read it because I could not find it. And I also Googled RCOG 1 in 500 VBAC, uterine rupture. Like I was trying to find where did this number come from? But this question made me think of another recent interaction I had over on social media when a reader said, I was planning a vaginal birth after 4 cesareans, and I found a study that said the risk of uterine rupture was 0.05% after 4 C-sections. And I was like, I would love to read this study. Can you please share it with me? And she did. And it was a great example of how easy it is to get a little bit mixed up when you're reading medical research. So, what did this piece of research find? They did report that rate, and yet what they were looking at people who had 3, 4, and 5 prior C-sections. And they looked at how many people had uterine ruptures in each category divided by how many people had gave birth that year with those number of prior C-sections. Can anyone guess when I set up the study that way, what was missing? What do you think? The critical thing that was missing was reporting the rate of uterine rupture for those who labored and those who had repeat C-sections. Instead, it combined everyone together. Well, we know the overwhelming majority of people with 3, 4, or 5 prior C-sections have repeat C-sections. So I would guess an incredibly small number of people in that group actually labored. So this person thought the risk of uterine rupture was 0.05% without understanding that what this study had done was combined the uterine rupture rates for those who had repeat C-sections and those who labored. That does not give us the answer we're looking for. So this is why it's so important when you hear people say things online and, everyone loves to read their research and everyone loves to post links and this is what this says. Often people are misinterpreting what studies say. And unless you have the know-how of going and looking at the study, reading through how it was conducted, reading how they grouped the outcomes. I mean, there's about 10 to 12 different things I'm looking for every single time I read a piece of VBAC research. And if you go to vbacfacts.com and search Canadian study, I do that for a Canadian study and I walk you through my process of reading medical research. And if you read that article, you'll have a better understanding of how to make sense of medical research. But yeah, I'm so glad you asked that question because 1 in 500, that's not what the current RCOG VBAC guidelines state.
Thanks. I was very curious. I was like, oh, I wonder if Jen's
It's such a good question. Yeah.
Okay. Let's do this one because I love ending on positive. So what are some positive shifts? Well, it's a both. So what are some positive shifts you've seen in your time advocating for VBAC facts and some less encouraging shifts? So you can pick which way you want to start.
Yeah.
Start with the less and then end with the hope.
Yeah. Well, so I think so much of this is about perspective. When I had my C-section back in 2004, I think the VBAC rate was like 6%, 8%. Now it's about 14%. And so we could look at that in a couple different ways. We can say, wow, say it was 8%. The VBAC rate has almost doubled. That's incredible. We're moving in the right direction. Or we can choose to say, wow, it's been 21 years and it's still only 14%. So I choose to look at it as a both and. Yes, it's great. We're moving in the right direction. The VBAC rate is slowly, slowly, slowly creeping up in the US every year. And we still have a lot more work to do. There are still so many people who are told to this day, it's astonishing to me, to this day, great, you'll schedule you for your next C-section. There's no conversation. There's no even conveying that they have options. It's just, you'll have another C-section. And I think it's so important. I mean, one of the main things I want people to hear, parents and clinicians alike, VBAC is mainstream. VBAC is evidence-based. VBAC is recommended by national guidelines. And that's because it's what the evidence says. So when you hear people say, oh, VBAC is risky, oh, VBAC, you know what? Everything has risks and benefits. And that's not a cop-out. That's the reality. We have risks and benefits with VBAC. We have risks and benefits with elective repeat C-sections, and they are two different sets of risks. And only you can decide what set of risks is most tolerable to you. And that depends on a host of different factors. Some women don't care about having a vaginal birth. They're like, you know what? I'm going to have my second baby. I'm going to be done. It's going to be fantastic. That's wonderful. You should have the birth that you want. And for people who are like, I don't want a repeat C-section for one of the numerous reasons, then they should have access to that. And so if a provider treats you as if you are not very intelligent, or maybe selfish, or you don't really care about your baby, there could be a whole, I mean, that's one of the things we talk about in the truth about VBAC for families is all of the non-medical factors that impact how healthcare is accessed and dispensed. Things like being worried about litigation, things like not wanting to be called in at 2 o'clock in the morning. These are examples of non-medical factors that can impact the care that you receive. And you deserve better than that. You deserve a clinician who not only is aware of the evidence, but is also willing to honor your right to make your own informed decisions, with the caveat that you then own the responsibility for that outcome. Because what we don't want to happen is they honor your right to make this informed decision, and then you are the statistic and you go back and blame them. That's the challenge, right? Like someone is that number, whether it's a VBAC complication or a repeat C-section complication. It doesn't matter how small that number is. There are people who are that outcome, and the outcome is devastating. Fortunately, that's very rare. And there's a variety of things that we can do to improve the safety on the patient side, as well as on the clinician and facility side. And so that is what we can all work towards, is making sure that people have access to accurate information. And if you want to become part of that movement, follow ICAN, follow VBAC Facts, share our posts, get the word out there so that way more people know that VBAC is an option. We have over 1 million C-sections every single year in the US, and the majority of those are repeat C-sections. And I would argue the majority of those repeat C-sections are among people who never even knew VBAC was an option. And everyone deserves to know that they have options and to make a choice freely.
Totally agree. We did, like a small survey here in Santa Barbara with the VBAC ban. And at first, like when you had just started to come, people literally didn't know it was an option. They thought it was illegal. Like that myth actually existed in our community. It was,
Yeah.
so it's wild what kind of sticks. Are you good to answer maybe one more question from the
Sure.
chat?
It's a bonus question.
Bonus
Who's
question.
getting bonus
Um,
question?
the first one that was asked. Can scar tissue affect a VBAC?
Okay, so I was curious about this. So are we talking about uterine scar tissue? Are we talking about abdominal scar tissue, which is also called adhesions? I think the person who asked this question, it might have been, I think I saw it in our webinar chat. So if you're here,
In the chat. Let me see if
yeah,
she's
let us know. What kind of scar tissue are you talking about?
still
So
in. So,
uterine, okay, uterine scar tissue. Great question. I don't know the answer to that question. I'm curious, Anastasia, have you heard anything about uterine scar tissue impacting VBAC?
um, I heard, and this was just like a story. Now I'm trying to remember who it was, that she was attempting a VBAC and the doctor cleared out scar tissue when she had an unplanned repeat C-section to help
Okay.
for the next birth. Um, it's the only time I've heard it spoken about.
Yeah.
So I'm not sure. I do know that cervical scar tissue can be an issue because of dilation. So it can get like stuck. And I know providers who are super, really try hard to get people vaginal births. And so they'll work on
Yeah.
massaging if they feel a band of scar tissue. So in my post
Yeah.
op notes, they mentioned a lot of scar tissue from the first C-section. Did they
Yeah, so that's
Uh,
interesting. I mean, when I hear the phrase
LUS?
a lot of in the lower uterine segment,
Oh, okay, got it, got it.
um, yeah,
I
so
think
when I hear a lot of scar tissue from my first C-section, I feel like that's more abdominal because I'm thinking about what would be a lot of scar tissue on the uterus. Unless there was some, I don't know, I'm thinking about, yeah, I, and I also, I mean, that would be a great question to ask an OB at some point.
that's what I
And
was thinking.
I'm going to
Maybe
make it a point, yeah, of
I was
asking an
thinking
OB
we can
about
ask
that.
our OBs that we have about this and seeing
Yeah.
what we can try to do is just make a post about it if we can get some answers. I'm writing it down too. So
Yeah. Yeah. I mean, adhesions can, if we're talking about abdominal scar tissue, adhesions could have implications in terms of fertility because they can kink and twist the fallopian tubes and keep an egg or a fertilized egg from going out of the fallopian tube and into the uterus. So that would be a situation where we have an increased risk of ectopic pregnancy in the fallopian tubes. Adhesions can also kink and twist the bowels, resulting in bowel obstructions decades after surgery. Post-surgical adhesions are one of the leading causes of bowel obstructions in the US. And we can have those post-surgical adhesions anytime there's an abdominal surgery. So whether that's a C-section or a hysterectomy or any other abdominal surgery where we can have scar tissue develop can increase that risk of adhesions later on in life. And I talk a lot about adhesions because it is so important in the truth about VBAC for families.
yeah, I think the adhesions is one of the things that gets left out when people are getting risks for C.
Yes,
Yeah.
absolutely. Absolutely.
Yeah, it doesn't get talked about because it's something, and it's something like you said that could show up years later. So, all right.
Yeah.
Well, it's 4:03. We did not get all the questions in the chat, and I left didn't get every single one, but we got most through most of the questions.
We did a good
I'm
job. You know
impressed.
what? I would rather do a thorough job on a few questions and really give them the attention that they deserve rather than just like powering through. You
Yep.
know, that's just like the kind of person that I am, because that's also the kind of information I was looking for when I was pregnant after a C-section. People want to give you these quick questions and these quick answers, and it's like, wait, wait, wait. I know there's more here. I want to understand. I want to actually understand this concept. I don't want you to just give me the final three words that sum it up. I want to understand why it is that way. And so that's the way that I speak to other people because we are all intelligent people who have the right to understand how this all works, which is very different than like getting marching orders from someone and then going and doing something.
Yep.
I really want people to have a deep understanding. So that way, when they go talk, have these conversations with their clinicians, they're not just saying, well, blah, blah, blah. They're able to say blah, 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 and have a whole nuanced conversation. And I can tell you, when patients show up and have that level of knowledge and understanding, what I have heard from particularly OBs is that it enables them to relax because they know they're talking to someone who has a working knowledge of the risks and benefits and is able to truly make an informed decision. And that's what a lot of OBs want. That's what a lot of clinicians want, is for
Yep.
patients to be able to make truly informed decisions that aren't based on a lot of the Pollyanna stuff that's out there. And Pollyanna, for people, I don't know if that's a phrase anyone uses anymore, it means a little naive, a little like hopeful thinking. And I'm all about hopeful, like positive thinking, but I also think it's important, especially when we're talking about VBAC and people have a hard time accessing it, to be able to speak intelligently and competently about the evidence, because that is the language that your clinician is speaking. So if
Yep.
you want to come in, it's like you've got to speak their language. So
Yep.
this is why I do what I do. If you found today compelling, come learn more with me because there is still so much to say. There's so much to learn. And I have to tell you, I think I do a pretty fascinating and engaging conversation. I've gone to plenty of conferences where the content is important and yet the presenter, it's not something that is super engaging. And I want to make people, I want to create the environment for people to learn. And if people are going to learn, they have to stay awake. Step one. So come stay awake with me, learn with me, get the facts, and become an effective advocate so you can have the birth that you want.
Yeah. Well, I can testify that Jen will keep you awake and engaged. And she does. You do a great job of
Step
that.
one, stay awake.
But also I just want to tell everyone, like, thank you for coming, and just to know that ICAN always provides all of these free webinars, but we can't do it without some financial support. So if you guys are willing and able to donate anything, it's super helpful, especially as we're coming to the close of Cesarean Awareness Month, which is so important. And we're so grateful that Jen donated her time today. So please remember to go follow her on Instagram and Facebook and wherever you get your podcast.
The talk tick,
And all of the
I'm on the talk tick now after
Oh,
many years of, oh yes, I'm on
I need to
TikTok.
go follow you on there because, the teenage.
Oh goodness, I know I'm there. I'm like, I resisted it for so long, and I'm like, well, if that's where the people are, that's where I'll go. And you're not going to see me dancing. I'm sorry, I'm not going to be dancing. I'm not a good dancer, so you wouldn't enjoy it anyways. But you will hear me share all sorts of awesome information about VBAC.
Well, maybe
And if
in the
that's your
future
jam, come join me.
soon. So, oh, someone said Substack. Are you on Substack?
I'm not, but that would be, I mean, that's a great idea.
Oh,
It might be, sometimes people use the language, the name of my company, the name of my courses in their own promotional material in order to confuse the public and get people to basically follow them. So the thing that's really important is when you Google VBAC facts, make sure you're going to vbacfacts.com. Make sure it's actually Jen Camel at VBAC Facts, because you might very well be coming across some imposters who want to ride on the coattail of the reputation I've spent 18 years developing. And you want the real deal? Come to vbacfacts.com.
yeah. And SEO is a weird thing too. So it will
Yes, it is.
do
Yes, it
weird things.
is.
But yes, she's simple. It's simple to find you. Just
That's right.
feedback.com. And that
Yeah.
is where you will find her. And then you can go from there and follow. But if that helps me sometimes to make sure I get the right spot. So thank you everyone for attending and sending in great questions and awesome questions and following up with great questions. And yeah, follow all the things.
This has been awesome, Anastasia. Thank you
Thank
so much for
you.
having me. And again, I want to thank everyone for attending too. I value your time. I hope you found this valuable. And I wish you the best of luck on your journey, whether you are a parent or a clinician. And again, we have resources for both at vbacfacts.com.
Thanks, everyone. Bye.
Thank you. Bye.
Bye.